Now we're going to do the neurological exam for the upper quarter. When should you do the neurological exam is any signs or symptoms past the acromion process. And if a patient complains of numbness or tingling, you definitely are required to do the sensory part of the examination. But if they don't, then you don't necessarily have to do the sensory part of the examination. So there are three components to the neuroexamination, looking at motor, sensory, and reflexes. So the first we're going to look at motor. So here I'm going to look at C12. So I'm going to ask the patient to apply pressure into my hand. I'm going to hold for 3 seconds and then relax and have the patient relax. Now, I don't want to let go once they relax because they're going to bob their head and they probably won't like that. And then also going into extension, applying pressure, and hold for a 3-second count and then relax. That's C12. For C3, I'm going to side bend and hold here and relax. And here I can stabilize myself putting my hand here and going side bend to the right, looking at C3. Looking at C4, I'm going to have the patient bring their shoulders, do a shoulder shrug, hold that position, going to come down and apply pressure. C4. C5, I'm going to put their arm into abduction. Ask the patient to hold this position. Don't let me push you down. I'm going to stabilize here and hold here for me. Hold, hold, and relax. And I'm going to test both the uninvolved and involved side. That's C5. For C6, look at biceps. I want you to hold here and don't let me push you down. And stabilize here. And that's C6. Also, for C6, you could do wrist extension and have them extend their wrist up, hold here, and don't let me push. C7, elbow extension. Don't let me bend your arm, so push into my hand, hold, 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 and relax. Also, you could test wrist flexion for C7. So I'll have them flex their wrist, hold right here, and don't let me extend. C8 is thumb extension, and I have them hold here, and don't let me push. T1, squeeze the fingers together, and don't let me pull them apart. And so I'm going to hold and put pressure. Again, testing the involved and uninvolved side. So that's the myotomes. The dermatomes are part of the motor exam. C1 is a little controversial whether there is a dermatome for C1. We're going to go from C2 on downwards. So here we're going to test both sides. It's going to have the patient first feel what it feels like in terms of the pinprick, whatever I use. I'm using the end of my reflex hammer. You could use the end of a safety pin or actually a pinprick needle. And have them get a sense of what that feels like. Then I'm going to follow for C2 and ask for any change. And then C3 along the neck and ask for any change, comparing both sides. C4 along the upper trap and asking for any change. Now I'm going to pick the most areas, the zones of each dermatome versus going through the entire dermatome. And we're going to go C5 along the radial styloid process and comparing both sides. That's C5. C6 is thumb. C7 is index finger. C8 is little finger. And T1 is the ulnar styloid process. And then T2 inside of the biceps area. So those are the dermatomes for the upper quarter. Now we're going to look at reflexes. I tend to like to do reflexes supine. You can do them sitting, but I'm going to show them supine. So let me have you on your back. Here the patient's nice and relaxed. With this position, what you want to make sure to get a good reflex on the biceps tendon, you want to put some pressure on it. So you want to find the biceps tendon, put a little stress, put him a little bit of elbow flexion, and then you're going to do a nice little tap. And here, I'm not sure if you can see, his biceps is flexing a little bit. And we're going to do 6 times. Looking for a quality, so looking that it's consistent, hyperreflexive, because sometimes doing once or twice is not enough. You want to see, is the strength consistent each time? So that's around the C5-6 level. Excuse me. C6-7, triceps. Once again, getting a bit of a stretch on that triceps tendon and tapping it. And I'm not getting, there we go, a little more consistent. Doing 6 times. Again, assessing both sides. Looking for either hyper, hypo, reflexive, or normal response. So we're testing both sides. And that concludes the neurological exam for the upper quarter. So now we're going to look at the neural dynamics of the upper quarter. And so there are basically 4 different tests that we can look at. We're looking upper limb tension 1, upper limb tension 2A, 2B, and upper limb tension 3. So this is upper limb tension 1, which biases more the median nerve than any of the other nerves. As any part of the examination, we're going to establish resting symptoms. And this part, usually what I'll tell patients, what I'm going to tell them is that at some point in the examination, I'm going to have them move their head in this direction and then move their head in this direction. So making sure you're consistent. If you had a pillow when you did the examination, use a pillow. If you didn't use a pillow, don't use a pillow, because that will change the results of the test. So here, this is upper limb tension 1. I'm going to have my forearm here. I'm just keeping it there just to keep some pressure on the shoulder, but I'm not depressing in any way. I'm just keeping it right here. Any symptoms? No? Now I'm going to take them into shoulder abduction, about 100 to 110 degrees of abduction. Any symptoms? Next, I'm going to take them into forearm supination. Any symptoms? Then I'm going to take them into external rotation. Any symptoms? Now I'm going to take them into wrist extension. Any symptoms? Then I'm going to stress a little bit more with wrist extension and finger and thumb extension. Any symptoms there? No. Then I'm going to take them into elbow extension. And here, feeling for resistance, R1, any pain, taking them to their end range. So let's say symptoms were provoked in this position. Then I'd have them say, I'll ask them to move their left ear to their left shoulder and ask them any increase in symptoms. And with Jason there were. Have them come back and then ask them, is there any increase or decrease in symptoms? Decrease in symptoms. And come off of it. And that's the upper limb tension 1 test. Again, what we're looking for with upper limb tension tests, we're looking for reproduction of the patient's symptoms. I've compared their uninvolved sides, so I've seen what their normal range is. And then looking at a distal component, whether it be wrist extension or side flexion of the neck, and seeing how that influences their pain. So I want those 3 results to, and if I get those 3 results, then I can pretty much say that there's something going on with their dynamics of their nervous system that's influencing their pain. And so that may need to be addressed. Now for upper limb tension 3, which stresses the ulnar portion of the ulnar nerve. I'm going to have the patient, again, in this position, establish any resting symptoms. I'm going to go into forearm pronation, any increase in symptoms. No. I'm going to go into wrist extension, maintaining forearm pronation, going into wrist extension, emphasizing more the ulnar aspect to really stress that, any increase in symptoms. I'm going to go into elbow flexion, any increase in symptoms. I'm going to go into shoulder lateral rotation, any increase in symptoms there. And then I'm going to go into shoulder abduction, maintaining each component and determining any increase in symptoms. And how are we doing? Okay. So let's say that increased their symptoms, then I'd have them bring your left ear to your left shoulder, any increase in symptoms, and then bring them back and bring their right ear to their right shoulder, any increase or decrease in their symptoms there. So that's the upper limb tension 3 test, emphasizing the ulnar nerve distribution. Now we're going to look at upper limb tension 2A and 2B. 2A stresses more the median nerve, 2B more the radial nerve. This is a nice test if you're looking at someone who has adhesive capsulitis and they don't have good range of motion, obviously in external rotation, but you want to see if there's a component of neural dynamics that might be influencing this patient's pain or range. This can be a nice test, a variance of looking at the median nerve in this position. So I'm going to have the patient come a little bit closer to me. I'm going to actually have them angled so that their shoulder is off the table, because I'm going to be doing a little bit of subtle depression on their shoulder. So you want them angled, and you want to make sure their head is kind of in a neutral position. And again, I'm going to tell them, I'm going to have you bring your head out here and out here, although that may not work, so I may have them go a little bit, so there we go, so that their head is supported. So once again, I want to start them in a neutral position, establish any resting symptoms. With each of this test, as I add each component, I want to see the influence of the patient's symptoms. This is the difficulty of this test, is holding that component, maintaining each component, but also asking the patient, has their symptoms changed? Any symptoms right now? No? Okay, good. So I'm going to add a little bit of shoulder depression. Any increase in symptoms? I'm going to bring my hand, I'm going to take them into elbow extension. Any increase in symptoms? I'm going to maintain that elbow extension and take them into forearm pronation. I'm sorry, this is what I'm testing here is actually the radial nerve bias. Rather than I said originally was the median, this is the radial nerve. Any increase? No. I'm going to take them into wrist flexion and ulnar deviation. Any increase in symptoms? Yep. No increase in symptoms in the forearm. So I might stop the test there and ask them, oh, let me have you bring your left ear to your left shoulder. Any increase or decrease in symptoms? A little increase. Okay. So let's say that the position of wrist flexion didn't increase the symptoms. I'm going to have them take their thumb and curl their fingers over their thumb, hold the flexion and ulnar deviation, and then take them into abduction, would be the last component, shoulder abduction. Now I'm going to test upper limb tension 2A, which is more biasing the median nerve. Same position start. Any symptoms? Going to add a little shoulder depression. Any symptoms? No. Going to go into elbow extension. Any symptoms? No. Going to go into forearm supination. Any symptoms? Going to go into finger and wrist extension. Any change in symptoms there? And then the end of the test would be shoulder abduction. But if I did reproduce their symptoms already in this position, then I would maintain that position and have them side bend to the left and to the right and see if it changed whether it be elbow pain, shoulder pain, wrist pain.